So in true brief intervention fashion, I'm going to talk to you all today for about 10 or 12 minutes regarding brief interventions as an adjunct to supplement sobriety. This is normally the part where I would look out into Glazer and see a bunch of familiar faces and then say it's nice to see familiar faces, but I do know that we have a number of familiar faces joining us digitally and virtually today. So it's good to see folks that way, at least to see your names in the bars. I have no disclosures. So for the next 12 minutes or so, some of the things that we're going to do is to think a little bit about brief interventions, if they work or not, should we be using them? We're primarily going to be talking about in the outpatient setting. So think about scenarios where you have 5 minutes, 10 minutes in a visit that's available. How do you adjunct whatever your primary intervention is? And then after we contextualize brief interventions and whether they're efficacious or not, then talking about a few different brief intervention approaches that you could pick up yourself. So the most important thing to start off with is that this is an adjunct. This is not a primary intervention, the things that we're going to be talking about. So there's lots of data to show that other interventions, behavioral health interventions, intensive outpatient therapy, those are the primary interventions you should be looking at when you're looking at sobriety for patients who are working with substance abuse or substance dependence. So this is primarily an adjunct to those. Whether it works or not in terms of efficacy, there is a good amount of data that shows that it is efficacious to a degree with brief interventions. So looking at systematic review in 2013 with 42 reviews over 40 years, they did find overall that brief interventions increased sobriety rates from 1 to 3%, depending on the study, over a baseline rate, control rate of 2 to 3%. Now, if you look at that on a larger scale, there is a follow-up in 2015 that showed that, again, kind of following on the right side, you can see that the highlight that there's a 2% increase in sobriety over baseline. And if you're looking all the way down here, I apologize for the micro font here, but if you look at interventions such as nicotine replacement, and pretty much all of the talks or all of the studies I'm referencing today are with smoking cessation. And so the other caveat is you're going to have to do some extrapolation on thinking about substance use or substance dependence and whether this data could theoretically apply to that, because there isn't a ton of data with in areas that aren't really with smoking cessation. But you can see on the right that the latest data, so this was a 2015 review, really reinforced that there is a statistically significant improvement with brief interventions. But if you're also looking at on a cost effectiveness scale, globally, this is a study that looked at countries with different GDPs and whether certain interventions were cost effective or not. And so the formula that they used was on the left, the per capita GDP over cost per life year gained. And if that number was greater than 1, they deemed that to be cost effective. I'll let everyone listening decide on whether you deem that to be cost effective or not. But the researchers, this is what they used in their model. And so when you look at the far right side with, for instance, automated text messaging and high income countries, 109 is showing it to be very cost effective in terms of an intervention. So when you're looking at low income countries, which I was more interested in this particular scenario, you can see that there's the top 3 interventions, and the one we're looking at is the brief interventions. Number 2, brief health worker advice, was cost effective in all formats. And as you go into higher income countries, the cost effectiveness actually goes up and up. So let's do a couple of case studies. We know that, yes, it's helpful to a degree, it's statistically significant, it's cost effective. But what are some of the tools when studies cite brief interventions or mindfulness? I know for myself, I don't really know what that means necessarily. So my goal for us today is to take one or two approaches that you can use that in that 5 or 7 minutes. So meet Oblong. So Oblong has age unknown. He has a 25-year, or they have a 25-year smoking history, and they're currently on nicotine replacement therapy. And remember, at the very bottom of that graph, nicotine replacement therapy was the most effective in terms of smoking cessation rates. And you have 5 minutes left in your visit. You have a choice. You have a dilemma at this point. Do I cut the visit now and move on to save time in my day, or do I try to do something in terms of brief intervention? You muster up the energy to do a brief intervention. And so one possible avenue for you is urge surfing. So urge surfing is an approach where you as a provider, or you as somebody who's creating the intervention, tries to coach the individual on what they call riding the wave of the urges or the maladaptive behaviors versus trying to fight the waves or to succumb to the waves. And the idea with this approach is to not to eliminate the urges or the desires, but really to have somebody be mindful in the way that they move in parallel with the urges. This is not something that you're going to, unless you're highly skilled and got lots of time in your visit, you're probably not going to sit there and coach somebody on how to do urge surfing. This is more of saying this is an approach that's out there that may work for you. And ultimately, what you're going to do is you're going to connect them to resources. I'm noticing in my slide right now, my next slide, I'm going to go quickly over it because I have a different updated slide. But with urge surfing, there's a number of different resources out there. Primarily on YouTube, there's a bunch of free resources, but there's also many apps out there that also talk about urge surfing. So really, I would encourage folks, if you have an AVS, or if you don't have an AVS yet on smoking cessation or even supplementing sobriety, to think about some of these resources out there for folks, because really it's going to be coaching them in their own time and space to do some of this work. And one of the big studies, I'm going to have to thank Sam Rennebaum 100 times in this talk, but he sent this over to me. So this is out of the University of Washington, which is just down the street, where they did one of the more famous urge surfing studies, where they took college students who were current smokers, and they randomized them to control and to an intervention, which was primarily mindfulness / urge surfing. And what they did is they put them in a scenario where they tried to elicit the urges of wanting to smoke. And then they monitor, I know, is it great? They monitor them for 7 days after that. And so what they found, and I don't have all the graphs on here, but what they found is the number of urges did not statistically change for the urge surfing group. But what did change is the number of cigarettes consumed. So the urge surfing group was down 1.55 cigarettes versus 0.53 for the control group, which is great for the control group too. Granted, this is only for 7 days, and then a 26% versus 11% decrease, which was statistically significant. So again, the thought is not to reduce the urges, but to learn how to move in parallel with them. You move on to your next visit. So this is Mr. P. Entagon V. He comes from a aristocratic line of geometric figures. And so you've known Mr. P. Entagon V for many years. You also know that he has a short temper. And the VRI isn't working today. What's new? It's never working. And so he's a little bit upset, and you don't blame him for it. But you also know, because you know him so well, that when he gets upset, it also triggers him to want to smoke, which is often. So you have 7 minutes left in your office visit, and you're thinking, again, do I move on? You know, you're already running late with this patient. So you're like, I really got to actually sit here with them and give them, you know, the time that they deserve. So behavioral activation replacement, that I dubbed as BAR, that is not an actual acronym that I believe is used for it, but it's useful for my purposes here today. And so the idea here is to replace harmful behaviors with behaviors that are satisfying and meaningful. And satisfying and meaningful don't always have to be have like a good connotation. So for this instance, for Mr. P. Entagon the fifth, it may not be you're saying let's replace when you're angry and smoking with mindfulness techniques, because that might not satisfy that activation energy. So it may be I need to pump some iron. Look at his arms; they're very like small and thin, and so maybe it's him trying to get some of that energy out and that frustration out. This requires you to know the patient quite well, and so that's why we chose this patient, because you've known him for years, and you know what are triggers for them to smoke, but you also know them enough that you can have a conversation or already know what might be activities that he can use to replace this. And so you're filling the time, the energy, the functional void left by the addiction. And so thinking about it in all those time frames, what's a replacement that has the right amount of time, the right amount of energy, and the right amount of function? And so I use the acronym BAR because then I can use the term raising the bar. And what you're really trying to do is trying to increase the threshold that somebody's going to participate in whatever the harmful behavior is. And so where they hit, before they hit that threshold, is that activity that you discussed with them. Finally, let's meet Jerry. Jerry was in a motor vehicle accident 12 years ago, developed opiate dependence, wants to try and taper dosing with eventual cessation. You have 8 minutes left in your office visit, just like I have 3 minutes left in my talk right now. So the last thing we're going to do is amplifying change talk. People are pretty familiar with change talk, I believe, especially with motivational interviewing. And what you're trying to do here are two ideas. One is to actively identify the change talk or the change narrative that the patient is volunteering. So you're actively identifying, but they're actively presenting those narratives. And what you're trying to do is send those narratives back to the patient so they can hear it in a third person format as well. One analogy, and again, Sam Rennebaum gets credit here. This is not his analogy, but it's one that I adapted from his, is to feed Mario. If you know Mario well, Mario has the mushroom, Mario gets bigger and more powerful. And as you feed the patient these change narratives that they're eliciting themselves, they become stronger over time as well in thought. And really the acronym we use for change talk is DARN. So desire, in a sense, a desire wanting to change. I want to change or stop because I want to be a good parent. The ability, I can stop anytime that I want to, which I think is a little bit more difficult. You really have to pump that one up, because I think a lot of people can say that flippantly. Reason, my relationship with my children has deteriorated and I really want to gain sobriety or taper down X because of my children. And then need, I could lose my kids, whether it's court mandated or just relationally if I don't change now. And the thought here again is sticking with the Mario theme. You're not just pumping Mario up with giving them the change narratives, but you're also putting some money in the bank in that you may not get change at that visit, but over time in a longitudinal fashion, when you know this patient, you're really giving them these narratives to put into the bank. And then over time, that really will hopefully amplify change. So in summary, brief interventions are not the primary interventions. They're adjuncts to use to your primary modality. If you have 5 or 10 minutes in your visit, consider some of these tools. So urge surfing, raising the bar with behavioral activation replacement, and then amplifying and redirecting change talk back at the patient. Huge thank you to Sam Rennebaum for the 3rd time, but it really should be 10 times because a lot of the ideas in this talk came from me sending him an email and asking him about his expertise. Want to thank Maureen Brown and Belinda Fu for putting together this talk or the CME year after year. John Stevens for leading our addiction medicine curriculum, and then our admin team who always does a great job in putting this event together. That's my talk. I don't know if we have any time for questions or any questions at all. If not, I don't see anything flashing. We're going to go ahead into a 10-minute break, and then we'll come back with Dr. Jess Sullivan, who will be talking about complex inductions.